Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. If this is the first time you're watching one of my procedures, please do feel free to like, comment, share. If you're watching on YouTube, please do subscribe. Similarly, if you're watching on Facebook or Instagram, please do follow. So we have a client here who attended with blocked left ear. So this is the left ear, and it was a sudden drop in his hearing this morning, and so he called in as an emergency. I was in the clinic today doing some admin work. It's been a really busy week, and the patient left a voicemail, which I got as an email. So as soon as I received it, I did give the client a call. So if you can come straight away, I'm happy to see you. But as you can see, with the left ear, the ear wasn't fully blocked with wax. So there was a partial occlusion, partial blockage, but not enough for me to feel as though that was the cause of the patient's sudden loss of hearing in the left ear. Now, we weren't able to perform microsuction in this ear, or in either ear actually. In fact, you'll see in a moment the right ear, which we'll do in the second ear, that we'll do the procedure in, was actually even more full of wax, but we weren't able to perform microsuction in either ear because the patient suffers from hyperacusis and also suffers from tinnitus. So hyperacusis is a sensitivity to sound. So whereas sounds that I would perceive as being soft or even moderately loud, someone with hyperacusis would find that extremely loud or almost unbearable. Hyperacusis is a whole complex area, so I won't have enough time to discuss it in this particular video, but you can think about hyperacusis as someone who's being sensitive to sound, and there's many different causes as to why someone may experience sound sensitivity. And also the patient experiences tinnitus. So tinnitus is a ringing or a buzzing, typically noise inside the ear. Patients who suffer from severe hyperacusis and also severe tinnitus, they're contraindicated to have microsuction performed because microsuction is quite noisy and loud sounds can exacerbate one's hyperacusis and or tinnitus. So this patient previously had his cleaned elsewhere with microsuction, and he asked them to stop because of the noise. And according to the patient, they said, well, that's the only method by which they remove earwax. They do microsuction, but they don't use any mechanical instruments like ear hooks and Jobson horns or forceps. So for me, if you're calling yourself a clinical ear care specialist and you're offering microsuction, well, you should really be trained to use other instrumentation. And if you don't, I don't really think you can call yourself a clinical ear care specialist. Now, in a moment, you're going to see, it's going to be revealed the cause of this patient's sudden drop in the left hearing, and it's the patient's tympanic membrane. It's retracted. So this patient has developed eustachian tube dysfunction, and upon further probing after I cleaned the ear, the patient has had some nasal congestion in the left side of his nose. And we performed tympanometry, which is a pressure test designed to evaluate the function of the middle ear and to measure the air pressure behind the eardrum in the middle ear and compare it to the atmospheric air pressure. And when you've got eustachian tube dysfunction, so the eustachian tube is a narrow tube that connects the middle ear, so the middle ear is the cavity behind the eardrum, to the back of the nose. And we want the middle ear to be full of air and not fluid. So any fluid that's secreted by the lining of mucosa, the mucosal layer of skin in the middle ear, that fluid can drain away down the eustachian tube to the back of the nose in the nasopharynx. So the eustachian tube, one, acts as a drain pipe, but two, it acts as the pressure equalizer in the ear. So it equilibrates the air pressure behind the eardrum in the middle ear, so it's equal to that of the atmosphere. And that's when your eardrum is at its most compliant, right? It's most mobile. When we did the pressure test in the left ear, there was negative pressure behind the eardrum, and that's because the eustachian tube is blocked. There's no air behind the eardrum, so it creates a vacuum. And when you get a vacuum behind the eardrum in the middle ear, it sucks the eardrum inwards, and you could see on the left side the eardrum was pulled in, it's retracted. When you compare it to the right side, this is the right side, the eardrum looks more of a normal position. It doesn't look sucked in. So I'm just again using the Jobson horn, just removing this soft wax. Unfortunately, the wax was lateral. There was an opening for me to safely insert the Jobson horn in and behind the wax to extract. If this wax was a bit more deep, a bit more medial, and it's fully occluding, it would be very difficult to remove using mechanical instruments. So we're quite fortunate in that respect. So it's just some soft wax on the posterior canal wall. This is near the entrance. You can see a few hair strands there, so we know we're near the entrance. So these hair strands, the hair, what we call the cilia in the ear, they only grow in the outer third, the cartilaginous portion of the ear canal. So that's the patient's eardrum. Slightly dull, a very faint light reflex there, but the eardrum's not retracted like the left ear was. It's just got some residual wax on the roof of the ear canal there, but it's not really significant. So I think I'm just going to possibly go back in just to gently move it. Because we're on the cartilaginous portion, it's fine for us to do this. But again, if this is on the bony part, it would be very uncomfortable for the patient. So Jobson horn comes in many different names. It could be an ear spoon, an ear curette, Jobson horn. I tend to call it a Jobson horn. So this is some wax on the anterior wall, so the front part of the ear canal. Again, we're right near the entrance here. You can see the hair strands there. Just some soft, sticky wax and dead keratin that we're just removing. And in a moment, you'll get a view of the tympanic membrane on the right side. So I hope you enjoyed that video, guys, and you're all having a good weekend. And I shall upload some more videos in due course. Take care, bye.